Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, ladies and gentlemen. It is such a pleasure indeed to be a part of this wonderful conference, and I'm really grateful to the organizing committees for hosting this conference in such a difficult situation. And Sir Bilal, excuse me for pushing on because people really protesting. Yeah, you're just so wonderful. Thank you very much. You can make up for it later. We're going to talk about non-ST elevation MI. A lot has happened. This is greetings from the 4G Foundation Cardiac Center of Excellence. It's a 100-bed hospital coming up in Defense Chowk, Rawalpindi. We've heard so many stories about COVID and AIDS and so on and so forth. But yet the coronary heart disease remains the #1 killer for the average people. The mortality in 1950 when somebody was diagnosed with coronary heart disease was 45% in the first year. And since then there's been a gradual decline and the mortality now is less than 10%. And that has not been a sudden change. That has happened because of a sequence of events and procedures and drugs and concepts, and trials have played a huge role in bringing that mortality down. So we're going to talk about non-ST elevation MI, but see, the acute syndrome is a whole spectrum. It starts with unstable angina, non-ST elevation MI, and ST elevation MI, but the basic pathology is the same, and that is an atheroma. An atheroma which ruptures, and whether the atheroma ruptures at the same time there's thrombosis, and there's also autothrombolysis or fibrinolysis. So it depends upon how which system predominates. You'll have acute MI if you have a total occlusion. If it's intermittent occlusion, it's going to be a non-ST elevation MI, and if it's going to be very small thrombus, they might be just unstable angina. So that's again the same thing, that depending on the level of occlusion, you'll have the ST or a non-ST elevation MI, and that is what is the underlying basis. That's the unstable or vulnerable plaque, the TICFA, the thin cap fatty atheroma. You can see very thin cap, and that's very prone to rupture, and that cap is what actually the statin thicken, and that is what makes it stable and makes it look like this. The cap becomes thick with the statins and lipid-lowering philosophy. So that's what really happens. So you go through a series of history, ECG, and troponins, and you decide whether the patient has ST elevation MI, unstable angina, or whatever. But remember that unstable angina is a historical diagnosis. And so once somebody comes to you with chest pain, you have a series of differential diagnoses you got to go through. Troponins become very tricky because we get called for raised troponins. There's a huge list of cause of raised troponins. Please go over them and keep them in mind because everything with troponins will involve you. When angioplasty came into being and Andrew Grunzer gave his first lecture, the next year a surgeon gave a lecture about his thoughts of angioplasty. He thought it's like a butterfly which is going to come out and get caught in the web the very first year, and it's going to crash. But about 10 years ago, there was a huge debate on how to treat with non-ST elevation MI, and it was medical versus surgical, interventional, and predominantly, without a doubt, it became obvious that invasive strategy for non-ST elevation MI is a real game changer. So more of the same. So we stratify people with the TIMI score, and the higher the TIMI score, the higher the mortality. We're talking about the non-ST elevation MI. The higher the troponins, the higher the mortality. People go work on the gray score, which has the same significance. And so we go through this algorithm of history, troponins, and ECG, and we work out which patient needs based on the levels of different things, symptoms, stability, which have to be done immediately within 2 hours, which have to be done within 24 hours, which can be delayed, and which are low risk. So we're going to talk about it as we go along, and that's a little more elaboration of the very same strategy. This is a very old slide. When I was showing this to one of my friends, and he said, "Look, sir, your lecture's on non-ST elevation MI, and why are you talking about thrombolysis?" I said, "Just bear with me." When you thrombolize somebody, at the end of this exercise, only 25% vessels remain patent. The rest, there may be reclusion, there might be intermittent patency, or there may be no perfusion distally. So the net effect is that after thrombolysis, you've got only 25% patency. And that is the reason why with time the effect of thrombolysis comes down within even those 12 hours split, but the advantage of primary PCI persists. And so we know that the first hour is the golden hour, but for primary PCI it remains. And we've all talked about the urgency of therapy in acute MI and ST elevation MI, but we've never talked about the urgency of therapy in non-ST elevation MI. And this is exactly what Cha and his colleagues did in Korea. They looked at 3-year data of almost 6,500 people, and they found that those who presented late, like after 24 hours of chest pain, their door to balloon time was 72 hours. And I'm going to go to the next slide. And those who presented early within 24 hours, their door to balloon time was 3.5 hours. And the outcome was that the latecomers had a mortality of 17% over a 3-year period, and those who presented early had a mortality of 10% over a 3-year period. And the same applied for all-cause mortality, recurrent MI, and heart failures. So we all talked about early strategy for primary PCI, but we've ignored the subgroup of non-ST elevation MI. And why is that? It's because, number one, the symptoms are rather atypical. They are less severe. People tend to think that it's maybe something else. The doctor looks at it, takes his time, and the result is a delay. And a lot of these MIs, you'll find people admitted with ST elevation MI, non-STEMIs, and you find that the interval is totally gone. Now, how can a non-ST elevation MI reduce the LV? It's because it's actually an acute ST elevation MI which has presented late, and you label him because of ECG as a non-ST elevation MI, which actually it's an acute MI, ST elevation MI which is presented late. So please treat non-ST elevation MIs as urgently as you treat the ST elevation MIs. And like I said, very reason why these people are delayed, we just talked about them. And this has become very, very prominent in the COVID era, where everything was COVID and people were ignored, and non-ST elevations were more ignored than ST elevation MIs, and the outcome was much worse for these guys. So we've got to give the non-ST elevation MIs a lot more importance. Now time is short, so I'm going to rush through the latest guidelines. We know about class 1, class 2, and class 3. So pre-treatment before angiogram is very kosher. If there's a patient has a high risk, you can de-escalate from ticagrelor and prasugrel to clopidogrel. And of course, there were different choices of these two P2Y12 inhibitors, and the clopidogrel is the least potent, but it's very useful in high-risk patients and after the first. And the advantage of these other two are in acute syndromes. And so after you tidy over these few, 6 to 12 months, then go over to clopidogrel. And this is the suggestion for immediate invasive. There's a whole list of criteria within 2 hours, within 24 hours, and of course then the low risk, which you got to stratify. Like we had a very wonderful lecture by Dr. Jabbar about when to do a CT and stress test, so on and so forth. And so early invasive criteria are definitely there. They're all in the guideline. In interest of time, I'm not going to go through them, but and so radial access is superior, as is drug-eluting stents. Complete revascularization there's a lot of data on this and suggestions, but again, I think use your good common sense, which guys you're going to take. I don't believe this data, although data is very clear, but going over it is very pointless because we all have logistics and those kind of issues with this. So basically, the class 1 indication is for heparin. You can continue and combine heparin with clopidogrel and other things, and cangrelor, and those are 2A. And of course, then there's a further elaboration of what we just talked about, early invasive and late invasive. So this is important, that the dual antibiotic therapy needs to go on for a year, and for high bleeding risk, you can reduce it, but you got to make sure that for the first week, you got to give all the therapies. And then in very high risk, you can reduce it and based on the level of risk, you can reduce the dual antiplatelet for to a month or 6 months. But if there's a very high ischemic risk also, then you got to prolong this and make a judgment on this. So you got to use clinical judgment there. And so then there's a lot of discussion on the TAT, which is the triple antithrombotic versus the dual antithrombotic. So again, the concept is that if a patient has a very high bleeding risk, you go to a NOAC with a single antiplatelet after a month, and after a year you stay just on a NOAC. You stop the antiplatelets. That's really very challenging. I'm not sure how many of us will change our practice, but that's what the guidelines say. So that's what happens when you have a patient. You need to discharge him and on different therapies. It's all in the guidelines. There's guidelines on healthy living. There's guideline on diet. And so I'm sticking to time. Thank you very much.